Welcome this evening to our latest Exploring Ethics topic this evening on smart drugs. I'm Mike Kalichman. I'm co-director of the Center for Ethics in Science and Technology. From looking around the audience, I think a fair number of you have not been to our previous programs. So before I go much further, I'd just like to get a sort of a reality check. So how many of you are here because you heard about us through the Science Festival? Okay, so that's the Science Festival side of the room over there. That's pretty clear. And how many of you are here for the first Exploring Ethics program? This is the first time you've been here. Okay, and that's quite a few. So welcome to all of you. If you haven't figured out our format before, you will see it tonight, and hopefully you'll find it interesting and useful. There are a few logistic things I want to make sure I cover before we get started. One is that we are very interested in you in a couple of ways. One of them is that we want to know what you thought of tonight's program before it's over. So you should get an evaluation form available, I believe, on the table at the side. Or do you have them? Oh, you already distributed? Sorry, already distributed. So complete that to let us know what you liked or didn't like about the program, what you'd like to see us do in the future. Second, we have a survey that we're conducting that is relevant to something with the Science Festival. It sounds like a lot of you are not here because of the Science Festival. If you aren't aware of it, you have not been listening, but you should know that Expo Day is the culmination of about a month-long series of activities for the Science Festival in San Diego. And that day will be here in Balboa Park. Many of the museums that day will be free. There will be a huge number of activities related to science, and related to all of those activities, we will have an ethics in science activity here in the community forum, the same room at 1 o'clock and 2:30 p.m., if I'm remembering the times correctly, where we will go over the results of these surveys. So these surveys were passed out last month at our program, and they'll be passed out tonight again. We would rather you not vote twice, so if you filled it out last month, don't fill it out again, but we'll never know. So we're going to go over the results of those surveys and use that as a starting point to look at some of the ethical questions that go with those scientific questions that we have on the survey. If I can, I think I've covered the key points I wanted to do now. Yes? It's this Saturday. So all day, Balboa Park, and use public transportation, I think, is the recommendation, best recommendation to get in here. So tonight's topic on smart drugs, how smart are they? The idea is not that the drugs themselves necessarily are smart, but you have questions about, well, how good are they? Do they really help make people smarter? How smart is it to use those drugs? Are there reasons we should or shouldn't? And in that spirit, I think we do have a lot of people here who haven't been here before. I suspect some of you are here because you have not, we're not going to talk about any personal experience tonight, but some of you may know somebody who has used drugs for the purpose of not just solving a problem, solving a disease issue for them, such as a cognitive deficit if you're elderly or otherwise, but somebody who wants to be better than normal. How many of you know somebody as a student or as an adult worker who is taking a drug for those purposes, to be better than normal? Okay, so that's less than the 20% that many surveys suggest, which is interesting. I won't ask you for any personal details about what you have, but I do have a couple of brief questions for all of you. You're going to hear more about the drugs in a moment, but for all of you, if you knew that a drug was safe and effective to help improve your intelligence, and it was legal, is there anybody here who would not want to take that drug to be better than normal?
You mean we're supposed to believe the scientists?
Oh, okay. Well, somebody's saying, do you believe the scientists? For the moment, we will believe the scientists. We're going to move into a world of fantasy and assume that we really know the truth. And the truth is, the drug is safe and effective. How many people would not want to take that drug? Anybody? Just two people at the back that are with the Ethics Center. That's something, I don't know what that's about. So very few people know. Well, it will be interesting to see by the end of the program whether people change their views. The discussion tonight will be telling you something about the safety and effectiveness of those drugs. Some of you may have heard of some of this already. How many of you heard the KPBS program on this topic yesterday? So a few people. There is almost always, or so far always been, a KPBS These Days segment related to our program. And how many of you saw the program on Channel 6 this morning with Larry Hinman talking about smart drugs? Besides Larry, who was there. Okay. Okay, so only a couple of people. So anyway, our program tonight, we have a little bit different format than usual. We're going to have one speaker, and then 3 people from different backgrounds will come and join him. The speaker tonight is George Koob. You have details on each of the speakers in your handout. George is a very distinguished and well-established scientist here in San Diego at Scripps Research Institute. And he has done a tremendous amount on a variety of drugs that affect the brain, and has been very kindly agreed to come and talk to us tonight about the specific aspect of cognitive enhancement and using drugs in that way. So I want to welcome Dr. Koob, and I'll get his slides set up here. And you are all wired.
Well, hi, everybody. I have, in the interest of glasnost, I must confess that I do caffeine, all right? So I try to limit it to less than 3 coffee equivalents a day, but that's my first confession. Second thing is that I do know a lot about drugs, but I'd rather not turn this into me telling you what you didn't want to know or you do want to know about drugs. I think our focus tonight is going to be on some of these ethical issues. So the first thing is, what is the appeal of cognitive enhancing drugs? So I'm going to use some words interchangeably. The word cognitive enhancing drug is one that has been used a lot in the literature to designate what we call smart drugs. And a definition of that would be simply a drug that improves your performance in some cognitive domain, all right? So obviously, one appeal is to treat cognitive impairments in neuropsychiatric patients, and I would lump into that attentional deficit hyperactivity disorder. Another might be to help one study longer in school or any professional training exercise. And another one would be to work more effectively or better manage stressors. So what would be an example of that? Well, someone who is on shift work, or an air controller, or someone who had to shift their cycle dramatically, right? So the next question it is a big question, is what is required for the safe use of cognitive enhancing drugs? And that certainly just came up. And I think where the consensus I see in the field is that we need some work in this area. So scientists, doctors, policymakers should provide easy access to information about the advantages and dangers of using cognitive enhancing drugs. And such information should form the basis for clear guidelines for their future use. So what I've decided to do today is talk about one class of the smart drugs that I know a good bit about. I've spent probably 30 or 40 years studying some of these drugs. And I want to talk about what are some of their uses, what do these drugs do, and then what's the downside of using these drugs, and why is there a concern, why is there even an ethical discussion, or would they meet the criteria that Mike laid out to you that, well, what if we had a drug that improved your cognitive performance, had no side effects, absolutely, totally safe? I think you're going to see after my little discussion that these drugs do not meet that criterion, right? So, or as I like to tell my undergraduate students, there's no free ride when it comes to your brain, all right? So you got to pay for everything. So let's explore that a little bit. First of all, what are the drugs in this class? What does that big word mean? Well, indirect sympathomimetic is a name for a special class of stimulants. And these indirectly activate your sympathetic nervous system. And what do you use that for? Well, it's the opposite of your couch potato system. So when you're being chased by a bear, this system engages to give you the energy, suppress your immune system, or help suppress your immune system, and fight or flight. So the bronchial dilation you get to breathe more deeply, the increased energy you get, the shuttling of blood to your muscles so that you can run from the bear and climb up the tree and so forth. And that seems like an absurd analogy, but I understand that bears are moving into suburbs in the United States, so you never know, you might run into a bear. But anyway, the fight or flight, there are chemicals in our brain that are known as monoamines, or things that some of you have heard of these compounds, norepinephrine or adrenaline, noradrenaline. The British call it adrenaline. We call it epinephrine, same word, same substance. It's a hormone released by adrenal glands. It does all the things I was telling you about. Another one is dopamine, which is localized in your brain, that energizes most of your brain structures. And another one is serotonin, which many of you know is involved in antidepressant drug action. So these five drugs, drug classes, all activate those monoamine systems, and they activate the fight or flight response of your body. And they don't just activate your brain, they activate your whole body through the sympathetic nervous system. So cocaine you're all familiar with. Amphetamines, you'd say, well, who would ever get amphetamines? Well, actually, Adderall, the drug that's used for the treatment of attentional deficit hyperactivity disorder, is a mixture of different amphetamine isomers. Frankly, it's just basically D-amphetamine. Methamphetamine is simply, or ICE, or you know the street names of this drug. Methamphetamine is simply a methylated form of D-amphetamine, and it gets to your brain just a slight bit faster than D-amphetamine. Phenmetrazine was a drug that was used for weight control in Europe. There was a big epidemic in Sweden back in the 70s. They took it off the market, but it's still listed. Methylphenidate, of course, is Ritalin, and there are many varieties and forms of methylphenidate used for the treatment of attentional deficit hyperactivity disorder. And the latest drug is modafinil, which is a very interesting drug that we don't know as much about as you might think as scientists. It's called Provigil, and it's used in the treatment of narcolepsy. And it will sustain wakefulness. Now, what do these drugs generally do for you? Before I get to ADHD, what do these drugs generally do for you? Well, and when do they have beneficial effects? And as people are always asking me, do they really improve your cognitive performance? Well, if you're fatigued, if you're worn out, if you're tired, if you're strung out, if you've pulled 3 all-nighters in a row, these drugs have enormous beneficial effects in sustaining performance in the face of fatigue. We've known that about amphetamines since the 1940s. They have been used by the armed forces of virtually every country in the world to sustain performance by their soldiers in situations of fatigue. They still are. All right? That's what amphetamines were originally, well, they originally developed actually to clear your bronchial tubes when you had a cold. And those were the famous Benzedrine inhalers. Of course, they got taken off the market fairly rapidly when people figured out you could strip them out and inject the amphetamine. So these drugs do improve performance dramatically in situations where there's a deficit of performance. Now that takes us, but what about normal people, regular people, well-rested, with an adequately, brain that's adequately got enough nutrition, proper nutrition, you get your vitamins, you eat your veggies and your fruits, you get a good night's sleep, you exercise regularly, and you're in good shape. Well, the effects are fairly minor, I must say. And what we'll see as we go through the lecture is they can actually have the opposite effect depending on the task that's involved that you're doing when you're in the influence of the drug or on the influence of the drug. Okay, so let's talk about ADHD for just a minute. I always like this cartoon. I use it for my undergraduates. I think I have attention deficit disorder. What's that? I saw something about it on TV when I was channel surfing last night. Didn't catch the whole thing, but I got the gist of it. It's a trendy new neurological syndrome characterized by obnoxious remarks, impulsive behavior, and God, you're ugly. It explains why I'm so rude, why I'm so impatient, and why I'm so agitated, and why you should keep your big yap shut. It explains both my extreme sensitivity and my extreme insensitivity. But now that I've identified the source of my problems, my troubles are over. The other guy says, I think I have attention deficit disorder too. What's that? So, and why did I put that cartoon in there? I didn't want to disrespect attentional deficit disorder. It is a very real and serious disorder for a lot of children and adults. But there is controversy about what constitutes attention deficit hyperactivity disorder. And if you go through the literature very carefully, you find that definitely about 8% of the population probably have this disorder. A possible 16% of the population have this disorder. And 72% of the individuals who do have the definite category, so 3/4 of the people that do have ADHD, by anybody's measure, standardized testing, even, number of psychiatric interviews, and so forth, 3/4 of them are on stimulant medication. And stimulant medication does work for attentional deficit hyperactivity disorder. The other part that's interesting is it's 3-to-1 male. That means if you were to do these numbers, that means roughly 15% perhaps, or maybe 12 to 15% of males in this country have ADHD. So it is a fairly large number and significant. You all know what it's like if you've ever met a child that really has serious ADHD. This is just kind of the developmental time course. You can read this. I'm not going to go through the whole thing, but the point I want to make from this slide is that it is a real syndrome with real problems that can be devastating to the child and to peer relationships, particularly peer relationships. So in preschool, these are children that are inattentive, they're slow to learn to read, they often have behavior problems. As you move up through development, the hyperactivity associated with attention deficit hyperactivity disorder tends to fade away, and but what is retained is poor follow-through, poor organizations, inability to complete tasks, and still that problem with concentration and attention. And it often moves into adulthood and continues in those domains. So while an adult may not be hyperactive by anybody's standards that has the disorder, they may still retain this attention problem. So over the years, the first drugs that were used for this were in fact D-amphetamine, then followed by methylphenidate, then followed by long-acting versions of methylphenidate, and now Adderall, which is a mixture of amphetamines. But these drugs all seem to have beneficial effects on the symptoms associated with ADHD. So how do they work? Well, this is actually a slide from a lecture for undergraduates at UCSD, but one theory is they reverse a biochemical imbalance. Individuals have low dopamine in their frontal cortex, the front part of their brain, and this reinstates that dopamine by increasing the amount available while the drug is on board. Another is a simple behavioral explanation. And when I emphasize this point, these drugs focus behavior. So often people say, well, it's paradoxical because the child's hyperactive and you're giving them a drug that would make any one of us here very active and probably insomnia tonight. So how are you giving a drug that produces increased alertness to a child who's already hyper? Well, it's because these drugs do what we call in the business rate dependency. They decrease high rate behaviors and they increase low rate behaviors. So the net result of that is a focusing of behavior and a focusing of attention. And that's what I put in the last point there. But there are side effects with these medications, and some of them are quite significant, and they have to be monitored. So the drugs are supposed to be prescribed by a physician for the disorder. Now, if it's a clinical psychologist who's recommending the prescription, then they have to find a medical doctor who will write the prescription. And the reason is because the drugs, if you take them in the evening, they're going to produce insomnia. There's going to be sleep disturbances. If the dose is too high in a child, you're going to have insomnia. There's weight loss and appetite loss. I just found a paper, just came out about, I think, a week ago, showing that in a 3-year study of newly treated children, they followed them for 3 years, and they had their weights beforehand. These were children all diagnosed with ADHD, and they had a control group that was diagnosed but didn't get the drug. Followed them for 3 years, and there was a decrease of 1 inch in height, and I believe it was close to 5 pounds in weight in the drug group. There was an old story that, well, they would catch up on drug holidays, and they might on drug holidays, but in this particular study for 3 years, there was a side effect of weight loss and appetite loss. Something to consider. Do you really I mean, you know, want a developing child who doesn't need this drug having this kind of, if you will, side effect. Someone asked me about athletes taking amphetamine. I think it was on the radio yesterday. And you know, I said it was like shooting yourself in the foot. If you're taking a drug to improve your academic performance so you can make the football team, but you're losing weight and height in the process, is that really where you want to go? Another side effect is increased tension behaviors, and that makes sense because these are stimulants, and so there can be nail biting, and it can extend to even tics sometimes, and obviously there are great individual differences. And another is excessive perseveration, and I was alluding to this earlier, and there are a number of studies that have shown this in the literature. They're a little hard to find, but if you actually test adults and children who have received these drugs on cognitive tasks, you'll find that if the task requires focusing of behavior and stick-to-itiveness, these drugs are marvelous. But if you're asking the child or the adult to do a task where they have to switch their strategies, where they have to, in a sense, be creative, you lose the benefit and actually can see deficits. And so this is something that has to be really factored into that point I made at the very beginning, that scientists, policymakers, psychologists all have to get together to decide what is the appropriate use of drugs that have such powerful effects on our brain. And so what I just alluded to is what we call the inverted U-shaped function with stimulant drugs that would affect any one of us here in the room, and that is that these drugs will increase activity at low doses, but at high doses they can actually decrease activity because of an overfocusing, and sometimes that overfocusing can become pathological, which means not good. And in fact, if you gave a rat, a rodent, amphetamine, this is the kind of effect you would see. Now you say, well, why would you, what does this mean? This is all gobbledygook. Well, take your average Joe rat, all right? It's getting to be evening here, but if we were to test this rat during the daytime, rats sleep during the daytime. So if you put them down here, they would wander around for a few minutes and go to sleep. But if I gave them amphetamine, the rodent would, with a small injection of 1 milligram per kilogram, the animal would show all these behaviors you see here. If there was food out, he'd probably have a little gnaw on the food. He'd do some grooming, a little social investigation if there was another rodent around. He might even take a cat nap. He might do a little rearing, a little locomotion, explore the environment, but he'd be active the whole time I was talking, all right? But what happens if I give this rat, this rodent, a very high dose? And it's marked over there, 10 times higher dose. Well, the animal would show all these behaviors for about 5 minutes, but then they would settle into a very focused, head down, sniffing and gnawing in one place, and they wouldn't move. So that's basically what I showed you on this slide, this inverted U-shaped curve. And what we know is that the change in activity with psychostimulants of this class is due to an overfocusing. And you say, well, people don't show that. Yes, they do. Yes, they do. Emergency room individuals appear in psychiatric emergency rooms in San Diego County completely obtunded, catatonic. That means rigid, unresponsive. They start rushing them in for an imaging to find out whether they had a stroke. And, you know, a half an hour later, on the way into the imaging machine, they come out of it and start screaming for their lawyer. They have been so overstimulated by these drugs that they are focused into rigidity. And, you know, the milder forms of this were what happened in the 1950s when amphetamines were used for weight control. And so there was a lot of what I could call punding or stereotype behavior. People would spend hours during the day cleaning out the house or bathing or other things we won't speak about. All right. And the other part that you got to remember about these drugs is this inverted U-shaped curve shifts with the task involved. Okay? So let's use the football analogy. Your job is to block in the front line. All right? I don't know what that position's called, but you know, the point is you got to protect the quarterback, so you block, all right? And it's the fourth quarter, and you're exhausted. You take a large dose of a psychostimulant so that you're over on the far right of this curve. Well, is it going to impair your function? No. Your job is simply to block. So you're in the simple physical task curve there, the white line. And you're still good. You're blocking like crazy, and you're wide awake because you took this drug. But imagine you're the quarterback, and you took the drug. Now, what's your job? Your job is to find whoever's open out there and throw the ball to them, right? Well, what if you end up throwing the ball over and over and over again to the guy in the blue sweatshirt there, and you only throw it to him? You keep perseverating. Stereotype behavior. What's going to happen? You're going to lose the game. The other guy's going to say, hey, he always says to the guy with the blue shirt. That's the curve here that's the complex task. And so these are kind of things you have to remember with these drugs. They have many effects, and they're dose dependent, and they depend on the environment and the conditions in which they're taken. So here's a more sophisticated version of this, but this is the neurochemistry of the prefrontal function. And this is normal individuals, and basically arguing that in everyday life we use the dopamine in our frontal cortex to alert our frontal cortex to do executive functions, to make decisions. If it's a complex task and we're overstimulated, we start to see problems with too much dopamine in the frontal cortex. If it's a simpler task, task B, then we have an extension of the beneficial effects of overactivity of dopamine in the prefrontal cortex. And this graph, which comes from Cools and Robbins, is actually based on data in cognitive performance in human beings done with an automated neuropsychological test battery. So you don't have to read this, but this is the new drug. I put it up there because I don't know a lot about this drug, because I've never worked with this one in the laboratory, but it is a drug that's used, is promoted now as a wakefulness promoting agent. It's being used for ADHD, although I don't believe it's approved for that. It's off-label. No one really knows how it works. I mean, there's a thought that it does have some effects on dopamine, and again, a very recent study shows that it does increase dopamine moderately in the brain of human beings. This was done with imaging studies. It may also activate two other compounds that we know are involved in wakefulness: orexin, which is the protein that you're missing when you have narcolepsy, so that's an interesting one, and glutamate, which of course some of you know is a very excitatory neurotransmitter. To date, it's not a drug of dependence. It may be a drug of abuse if people are using it illegally. Same with methylphenidate. Methylphenidate is really not a drug of dependence. To my knowledge, there are not very many people that have been freebasing or intravenously injecting methylphenidate or modafinil. But when I queried 3 of my most prominent colleagues who work in the clinical aspects of these drugs, including the director of the National Institute on Drug Abuse, the one line they all wrote in the email was, yet. Yet. Okay? So I keep that in mind. The other thing is there aren't very many side effects attributed to modafinil yet. So this is approaching that drug that Mike was talking about, that maybe this is the perfect drug, keeps you awake, works on multiple parts of your brain involved in wakefulness. But the precautions are cardiovascular conditions, drug interactions, which is a big one because taking this drug may interact with other drugs. So the jury is out on modafinil, and I think caution is required knowing what we know about methylphenidate. So why are these drugs not drugs of addiction? Well, we don't know. One is pharmacokinetics, possibly, and what is pharmacokinetics? That's how fast the drug gets to your brain. It's very possible that cocaine and amphetamine, certainly methamphetamine, get to your brain much quicker than these drugs. Maybe they're a little less effective in producing the high, the euphoria. That's certainly one hypothesis that's out there. Maybe they're not readily smokable. I haven't tried. But generally, drug addiction is like water running down a hill. Drug addicts find a way. So be surprised if it hasn't been tried. Pharmacodynamic profile may also be different than cocaine. And Mike and I decided not to show a slide with all the complicated numbers. But in fact, methylphenidate has some serotonergic activity. Maybe that's what buffers it from having as much abuse potential as the more dopamine drugs. So what I said about pharmacokinetics is something, you may find this slightly tedious, but this is cocaine, and this applies to any drug. This would apply to methamphetamine, it applies to heroin, it applies to any drug. I mean, heroin was originally introduced by the Bayer Company orally as a treatment for cough, okay? It's a great cough medicine. It's super. But you got to keep people taking it orally for cough, all right? So this graph shows you, I think very dramatically, that if you take cocaine orally, it has a profile not unlike methylphenidate taken orally. But if you start taking it intranasally and snorting it, look how fast the onset is. And then look how fast the onset is if you take it intravenously. These are blood levels. It's immediate. And smoking crack cocaine is faster to the brain than intravenous injection. And that's true for every other drug as well, including nicotine, by the way. My colleagues that smoke hate it when I tell them they're freebasing nicotine. Okay, so this is all I have to say really about these drugs. I just wanted to point out to you that there are 3 psychostimulant drugs, methylphenidate, amphetamines, modafinil, on the market that allay fatigue and sustain performance. All 3 drugs are effective in treating neuropsychiatric neurological disorders, ADHD, narcolepsy. 2 of the drugs have significant side effects, and 1 of the drugs has high abuse potential, and that's amphetamines. I didn't even talk about that, but I assumed you all knew that. Psychostimulant cognitive enhancing drugs should be supervised by health professionals. That's why they're scheduled the way they're scheduled by the government. Now, the government doesn't get everything right, but I think it got that right, all right? And that was a combination of the FDA and other advisors that make those decisions. Cognitive enhancing drugs outside of the psychostimulant domain have limited effectiveness. They do work a little bit. The Alzheimer drug, donazepam, that's used as an anticholinesterase inhibitor that boosts your acetylcholine, has some real beneficial effect in Alzheimer's patients, but there's not a lot of evidence that it improves performance in non-Alzheimer's or non-demented patients. Cognitive enhancing drugs outside the psychostimulant domain that have milder side effects may require new regulations. We don't know what we're going to do about the drug that Mike proposed that we might eventually get. But let me tell you, after 30 years in research and watching this evolve, I have yet to see that drug come our way. And then finally, I made this point before, scientists, doctors, policymakers should provide easy access to information about the advantages and dangers of using cognitive enhancing drugs. So the last couple of slides are some questions that I hope will stimulate some discussion and lead to some of the other individuals who are participating into their domain. So should young children and adolescents with ADHD be prescribed cognitive enhancing drugs? Yes, but we know there are side effects. Should adults with cognitive problems of neuropsychiatric disorders be given cognitive enhancing drugs? Yes, indeed. But again, certainly with the aged population, we're going to have to be very careful about giving them stimulant drugs because of cardiovascular problems. I mean, all of these drugs release norepinephrine, which stimulate the heart, the ones I've talked about. Should cognitive enhancing drugs with mild side effects be prescribed more widely for other psychiatric disorders? Well, yes. I mean, there are other psychiatric disorders with cognitive problems like schizophrenia, but you don't want to give D-amphetamine or methylphenidate to a schizophrenic. Theoretically, it only makes the psychosis worse, right? So we're going to have to find some other class. And should cognitive enhancing drugs be allowed for simply boosting brain power in healthy people? Now, I wrote no, but. And that's where we get into some controversy. So what about the buts? Well, I already told you, significant side effects are produced by current medications in the psychostimulant category. Agreement and regulation of supervised use of cognitive enhancing drugs is required. And there are 4 areas, and I took this from a Nature paper that was written by the individuals down below, one of whom, by the way, is a Nobel Prize winner. That's Eric Kandel. The other is a main player in this is Barbara Sahakian, who's a professor at Cambridge, University of Cambridge in England. So they outline 4 areas that we need to be concerned about. 1 we've already talked about, so I don't have to dwell on this, safety. Number 2, coercion. Controls or standards will be needed for situations where people may be pressured to take cognitive enhancing drugs. You saw the thing that Mike put up there. What if it was true, the April Fool's joke, that the director of NIH, which There isn't one right now. But what if the director of NIH put out a bulletin and said everybody who submits a grant has to be on methylphenidate? Or what if all my colleagues are on methylphenidate? Am I then under pressure? Maybe I should be on methylphenidate. Maybe I'd write a better grant. Or maybe I just keep writing the same grant over and over again. And then distributive justice. This sounds like a big word for something. I mean, these are British people that wrote the articles. But regulations may be needed to prevent unfair advantage in competitive situations. What if it's only the cognoscenti that know about the fact that methylphenidate helps you do better on the SATs? And so it's only the people who have sons and daughters who are academics or professionals in San Diego. What about the other people? So how do we deal with these issues? These are big issues. And then finally, and this is the real ethical one, personhood and values. What it means to be a person and to value human life. How did taking a pill to become a super brain change that? There's a conflict here between self-improvement versus dignity and the value of hard work. And these are not resolved issues. I have no answers for this last one. But what if taking a drug that helps us with cognitive enhancement then ruins the possibility that in the future we're going to have the reserve, the insurance, if you will, to be able to perform under situations of stress when we don't have that drug? Or, put it very simply, what if your neurosurgeon always takes methylphenidate before surgery, and there's an emergency, and he has to go into the hospital and save somebody's life, and he hasn't taken his methylphenidate? So, we have to think about these issues. And that's it. So, thank you very much.